Everyone, it's Dr. Hodges. I wanted to add a little bit to part 2 of my YouTube Q&A potpourri. After I'll have different videos, a lot of times patients will leave me different questions in the comments. While I certainly tried to answer as many of these as I could, I thought it would be helpful if I made a group of videos that were answering some of my questions that patients have left. As a little side note, if patients are asking me a specific question to their health, especially if you are a former patient or a current patient of mine, and you're really just asking me a health question, listen, you gotta know, I can't answer that on social media. That is a HIPAA violation. It doesn't matter if you're like, I love you, Dr. Hodges, you're the greatest, and blah, 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 you're my doctor. Guess what? I can neither confirm nor deny. Usually what I'll say is like, I'm so happy you're doing well. I can't answer those kinds of questions. If you have an issue or specific concern, what I'm probably going to do is give you a canned answer that says, please call the office for an appointment, blah, 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 blah. What you really could do is call Benny. He's my MA. He could get the ball rolling for you. Or you can message my mom. She also can ask some questions. Or you can just call and make an appointment. But I'm not trying to be rude whenever I don't answer some of those questions specifically. I'm just not really allowed to answer those. A medical specific question to your health problem, I just can't do that on social media. It's not that I don't love you, it's just that I just can't. All right, well, let's get right into it. Part 2, I was trying to group some of these questions that patients had by topic. So the topics for today are really going to be surrounding kind of surgery specific questions. I have 5. So the first one is, I had my gallbladder out and now I have a lot of reflux disease. Can I still have a VSG? So for those out there that are not familiar with acronyms, VSG stands for vertical sleeve gastrectomy. That's just a fancy way of saying, I'm getting a sleeve gastrectomy, I'm getting that sleeve. So let's talk a little bit about reflux disease, bariatric surgery, and then specifically how it relates to the sleeve. With a sleeve gastrectomy, your stomach gets created by, you have this big floppy bag. That's what your stomach looks like. After a sleeve, I go in and I remove a large portion of it. You end up with a long, narrow tube. That's why it's called a sleeve. It's not that we're putting something around your stomach. It just means that your stomach goes to looking like a long, narrow column, like the sleeve of a shirt. Now, what that also means from a physics side, oh my goodness, I hated physics when I was an undergrad and in high school. Alas, there's physics all around us. Still have to know some of it because it affects us all, specifically if you've had a sleeve, because what the physics of your stomach now dictate is that that stomach is now a little bit more pressurized. You're at a much higher risk for developing reflux. In fact, 20 to upwards to 40% of patients that have never had any issues with reflux before will develop reflux after a sleeve gastrectomy. Certainly, if you have reflux before surgery, then you get a sleeve, there's a good chance that your reflux could even worsen. Now, about 8% of patients that undergo a sleeve will need to have some sort of revision surgery to treat their reflux. Typically, that's going to be conversion of a sleeve to a gastric bypass. If somebody has reflux, they come to see me, and they have what we call surgically correctable reflux disease. That just means that you have been on maximal medical therapy, which is usually an acid blocker twice a day for 3 months. You're still having symptoms. That means that you've failed medical therapy. If you have surgically treatable reflux, so you meet that little definition, then you're really going to be better served with a gastric bypass, because gastric bypass has been shown to treat reflux disease, whereas a sleeve gastrectomy has been shown to create reflux disease or make it worse. What do you do with that? I give this information to my patients. My non-starter for a patient is if they have Barrett's esophagus, I will not do a sleeve on them, because Barrett's esophagus is a precursor to potential esophageal cancer. I think it's interesting, in my training, we did surgical oncology. I saw 2 failed esophagectomies. It's just what that sounds like. The treatment for some folks, whenever they have esophageal cancer, is they have to get their esophagus whacked out, and they either bring up the stomach or they take a little piece of the colon, and then that serves as the new esophagus. I saw 2 colonic interposition grafts. They both of them failed. The patient had no esophagus. They ended up with a bag. Haven't you seen some people with an ostomy? It's even worse if your ostomy is on your neck. It was horrendous. And I got to experience that twice as a resident. I got to see what the poor little patient dealt with. I certainly saw what their surgeon was dealing with. It was not good on either end. For me to tell you guys that I am super aggressive with reflux control, especially if you have diabetes, is an understatement. Because in surgery, things could always be worse. We never say, it could be worse. It can always be worse in surgery. We just never say that. I mean, can you have a sleeve after you've had your gallbladder out and you have reflux? Yes, you can. Should you have a sleeve after you've had your gallbladder out and you have a bunch of reflux? Probably not. It really kind of depends on you. When you're telling me you have some reflux, does that mean that you just have to take your Papa Tums every now and then? It bothers you? It's probably going to get better with a bypass. Even though 40% of patients will develop reflux, 60% don't. If you're just popping the Tums every now and then, or maybe you need to take something over the counter, usually that does the trick. But it's okay if you miss every now and then. You just need to know that you are probably going to develop reflux after surgery. Instead of you just having to pop a Tums every now and then, more than likely, I would say, when I say more than likely, I said greater than 50% chance, because that means you have fairly frequent reflux. Probably going to have to take an acid blocker for the rest of your life. Just take one of those every day. Now, what happens if you're a patient that's like, I have really bad reflux. I have to take my medicine every day. Or maybe it's not just foods that can aggravate it. I might not be able to lay down. If I lay down flat, things are coming up. If you have an issue like that, you do not need to be getting a sleeve. Because I will tell you, your reflux is going to get much, much worse. The recommendation is now that even in the presence of a hiatal hernia is, or your hiatus, is the opening that the esophagus goes through to get to your stomach. If that's a little bit bigger than it should be, that's called a hiatal hernia. If you have surgically correctable reflux disease and your BMI is over 30, then the treatment really is gastric bypass with hiatal hernia repair. It's not just repairing the hiatal hernia. If you're a patient that has had a sleeve and you have surgically correctable reflux disease, you're just having horrendous reflux afterwards, it's usually not enough for you just to have your hiatus repaired. You really need to get that sleeve converted to a bypass. So repairing a hiatal hernia is like the cherry on top. It still doesn't address the intrinsic issues of reflux that are brought upon a patient whenever they've undergone a sleeve gastrectomy. Does that make sense? I really think it is a discussion that you need to have with your surgeon. One word of caution I would say is if you are going to a surgeon and all they do are sleeves, you gotta have Barrett's esophagus. That's the only surgery that they know how to do. So that is the only surgery they will offer you. And there are a number of them out there. Those same doctors are probably going to tell you, you're gonna be just fine. Maybe you will be, but I can tell you in my practice, probably gonna be doing a bunch of acid blockers. You know what I mean? So it really comes down to how severe and significant your reflux is, whether or not and regardless of why you have developed that reflux, if undergoing a sleeve is really a good option for you. So it's just a discussion that you really need to have with your surgeon, and make sure that your surgeon does more than just a sleeve gastrectomy. Otherwise, that's all they're going to offer you. You might not get the full picture. Can you, and one other little side note, if you have a sleeve and you're one of those 8% that needs to get it converted to a bypass, the success rate for your reflux is just under 90%. So about 87 to 89% of patients will have complete resolution of their reflux disease. That's pretty good odds. Question number 2, can you have a bypass surgery if you had gallstones? Yes. Can you have a sleeve if you have gallstones? Yes. It's not contraindicated. Just because you have gallstones, it does not mean that you need to have your gallbladder out. Only about 30% of patients that develop gallstones will ever need to have their gallbladder out. Doesn't mean if you have a sleeve or a bypass or one of those is better. I think one of the things to think about is, are your gallstones symptomatic? Some people will find out that they have gallstones because maybe they had a kidney stone and they had a CT or they had some imaging and it was just an incidental finding. They've never had symptoms of biliary disease. What are some of those symptoms? If you have like pain or bloating after you eat, it can be like in your mid belly, just under your chest. Some people might think that it is reflux when in fact it is what we call biliary colic. That just means pain in your gallbladder. That is secondary to the gallbladder, like squeezing on a little bag of rocks. But if you're asymptomatic, got a 70% chance of never needing that gallbladder out, whether you've had a sleeve or a bypass. On the other hand, if you are symptomatic, you've been to the ER once or twice, 3 times a lady. If you've gone to the ER more than one time for your gallbladder, it might be a prudent thing to do is have your gallbladder taken out at the time of your bariatric surgery. Again, that's just a discussion that you need to have with your bariatric surgeon. Right now, it is not the standard of care to have your gallbladder taken and removed at the time of your bariatric surgery. Back in the 70s and 80s, that is what was done. That's also like in the 1950s. If they went to your belly for any reason, they would always end up taking your appendix because they were like, well, your appendix is probably going to get sick at some point. We just got to take that thing. Well, we don't do that now. Oh my goodness, I've done thousands of bariatric surgeries. The majority of my patients still have their appendix. I haven't done an appy, I think probably since I was a third-year resident. I mean, I only know where the stupid appendix is because I'm always looking at that silly thing whenever I'm doing a duodenal switch. That's like it hangs off the colon right where the colon begins on the cecum. As far as yanking those things out, I haven't done that for a number of years. So you do not, it doesn't really matter if you have stones in your gallbladder. What really matters is, are you symptomatic from those gallstones? Let's see, I have one more question. I'm 3 days post-op and I have a cough. Can that cough cause a leak? I think that's a great question. The answer is no. When you've had weight loss surgery, your belly's gonna hurt. So the little alveoli, those little air pockets in your lungs, those can kind of collapse a little bit on themselves. That is called atelectasis. Atelectasis within the first 24 to 48 hours is the #1 cause of fever in a post-operative patient. For any of you budding students out there, that's what the answer is on the app site in surgery. 24 to 48 hours, atelectasis causes fever. And if you have not been walking a lot, or after surgery, we give you this little machine called an instenospirometer. We want you to take deep breaths in and out because what we're trying to do is keep those alveoli open. If you've just kind of been moping around, not really walking, and let's say we try to get you to move a little bit, maybe you've called and you're like, I have a fever. The doctor's gonna say, you need to get up and move. You need to be doing the instenospirometer whenever you go home. You might notice that you can have a little bit more coughing because it's kind of irritating for those little alveoli to open up. It's just irritating. That causes a cough. You coughing and having that kind of like that sudden increase in intra-abdominal pressure, that is not going to disrupt any staple line in your gut. What does predispose you to a leak or staple line breakdown? From a patient side, if you are anemic, if you have low protein, so you're malnourished, if you advance your diet too soon, if you take steroids or NSAIDs, those, or if you're on autoimmune medications, those are things that can inhibit or cause healing to be poor. That can predispose you to developing a leak. Whenever, as from a surgeon standpoint, whenever you're firing your stapler, or some people, if they hand sew, I know in my practice, I always test that staple line intraoperatively. So we place a little tube down the patient's mouth, guide it down the esophagus into the stomach. Then I inject some dye And I just want to make sure that I don't see any of that dye leaking out of that staple line. I test with both air and with blue dye. If my leak test is negative, then you don't have a leak. So, but if maybe there was a staple misfire, or if when you were creating your anastomosis, that's a hookup between the stomach and small bowel for bypasses and switches, if that staple line is on tension, that also predisposes you to a leak or a staple line failure. You getting up and coughing, you bending over, you having your big old hound dog jumping on your belly, that might hurt the incision or cause one of your incisions to come open on your skin. It's not going to do anything intra-abdominally. So cough away. It'll just be very uncomfortable. You may want to take a little pillow, give yourself a hug. If you think you're going to cough or sneeze, or whenever you're using that incentive spirometer and you're taking in those deep breaths, give yourself a hug. It's going to feel a lot better. And if you want to use like an abdominal binder or a waist trainer or a girdle or whatever you want to call it, you can certainly do that after surgery too, just to give you a little bit more support. Let's see. I thought I had one other question. There's a bunch on this one. In a patient with revision surgery, if you're undergoing a sleeve to satiety, is it okay to get private IV therapy for fluids if you're feeling that your fluids are low? Absolutely. It's totally fine. We actually send off a referral to home health for all of my patients. They run your insurance just to see if it's a covered benefit. If it is, they'll give you guys a call and say, we're going to send out a nurse just to give you a bag of fluids. If you're not feeling really dehydrated, you can always call and cancel. But yes, absolutely. If you feel like you're a little dehydrated, you're not keeping up with your water intake or your protein intake, going and get a bag of fluids, whether it's at a Care Now, Doc in the Box, hospital, one of those IV places, that's totally fine. I think one of the things to remember is that if you're going to one of these IV therapy places that's kind of bougie and they're like, you need this, that, and the other, you don't need any of that business. You need some normal saline. That is what you need. I would not recommend you get this big vitamin cocktail right after surgery if you're going to one of these like little bougie IV hydration places. All you need is a bag of saline. That is all you need. The reason why is if they put in too much potassium in that bag, you could have some significant issues with cardiac arrhythmias. And that's been known to happen. It's very rare, could happen. So if you're gonna go and get IV therapy and there's extra vitamins and all this stuff, that needs to be done like either by home health care agency, by one of the Care Nows, like a Doc in the Box, or at a hospital. That would be my other 2 cents. But totally fine. I think I have one more. Oh, if I have an essential medication, will taking an oral medication be an issue after surgery? I will tell all my patients for the first month after surgery, if you have a tablet that is larger than a baby aspirin, then you need to go ahead and cut that in half. You don't necessarily need to crush it. It's certainly going to be better if you cut that bad boy in half. That way it doesn't get stuck. I will tell you, allergy medicine, it always has that little enteric coating. That has gotten stuck. 2 times I've had to take patients back to pull Zyrtec. I'm sure it was Zyrtec. That's what they told me it was. No hit against Zyrtec. I always get Zyrtec from my daughter. It's great. I've had to pull that pill that was stuck in the patient's anastomosis. Can you take your pills after surgery? If they're essential, it's something that we're not stopping. You can absolutely take it. But if it's a great big horse pill, you're gonna have to cut it up in little chunks. If it is a capsule, you're gonna have to open up that capsule. You're gonna have to do that at least for the first month. So, hope that this was helpful. And one other side note, if I am not your surgeon, I have given you some instructions in this video. You are having surgery. I highly suggest that you go by and you talk about these same questions that you might have with your own surgeon to make sure that you are on the same page with them. So, hope that this was helpful.